Hello, I'm Bob Challoner, the President and CEO of Southampton Hospital, and I'd like to welcome you to another edition of Focus on Southampton Hospital, your monthly television program about the events and happenings at your community hospital. March is Colon Cancer Awareness Month. I'm actually wearing this pin in honor of Colon Cancer Awareness Month, an important disease in this country, and unfortunately a disease where not enough people are getting regular screening, a disease that with regular screening we can prevent and cure. To tell us about all of the effort around colon cancer screening today, we've invited Dr. Stephen Georgopoulos, one of our leading gastroenterologists, to talk to you.
Colorectal cancer involves tumors or growths that involve the rectum, defined as the lower 10 inches of the colon, as well as the more proximal colon, meaning the more 2 or 3 feet ahead of the rectum. This is any growth that can affect the colon, and unfortunately when it grows large, it can become unresectable and incurable. The goal of colon cancer screening is to catch these cancers early and hopefully prevent some colon cancers as well through colonoscopy. You'll be hearing a lot more about colorectal cancer in March. This March is Colorectal Cancer Awareness Month. Some physicians will be wearing this blue pin, such as I have on my lapel, for the hope for the future of colon cancer screening. Colon cancer is very prevalent in the United States. Approximately 150,000 cases will be diagnosed each and every year. That amounts to about 1 in 20 people, unfortunately, would be diagnosed with colorectal cancer. Also, unfortunately, approximately 50,000 people will pass away due to advanced colon cancer each and every year. Age over 50 is a significant risk factor. That's why screening usually begins at age 50. 90% of all colorectal cancers occur in patients over the age of 50. Obviously, the older you get, the more your risk would be. In studies, they've shown that patients 60 to 80 years old have a 50% more incidence of colorectal cancer than those under the age of 40. There are certain lifestyle factors that can affect one's risk for colorectal cancer. Eating diets high in fat, animal fat, milk products does increase risk of colorectal cancer. Contrary, maintaining a diet low in fat, low in meat products will reduce one's risk of getting colorectal cancer. Obesity, as we hear, is an epidemic in the United States. Obesity has conclusively been shown to be a risk factor for colorectal cancer. Obviously, dietary modification, limiting the number of calories with the appropriate type of calories, will reduce one's risk of getting colorectal cancer. Diet supplementation with folic acid and calcium has also been suggestive and shown to reduce risk of colorectal cancer. High fiber diet is a good idea for people to do not only for colorectal cancer prevention, but also for promoting overall good health. What I will say, though, is in spite of most gastroenterologists and physicians feeling that fiber supplementation is beneficial, this has been controversial in the literature. However, fiber diet supplementation has been proven beneficial for a host of other ailments that affect people, such as diabetes and coronary artery disease, so we still strongly recommend a diet high in fiber and fruits and vegetables. A lot of people don't appreciate what fiber is, and actually it's undigested plant product, and it's thought to be very beneficial. If you listen to Dr. Oz on TV, he calls it the broom of the colon, and we feel it is somewhat beneficial, although, as I said, unfortunately, studies have not conclusively proven this to be the case. Exercise most definitely affects people's risk of getting colorectal cancer. Those people that remain inactive have a higher risk of getting colorectal cancer. Obviously, the contrary is true. By maintaining a good exercise protocol, one can reduce their risk of getting colorectal cancer, and has also been shown to be beneficial for other ailments and reducing one's risk of coronary artery disease as well. What is considered a level of exercise that's satisfactory? That would be some sort of moderate exercise defined as 30 minutes of some moderate activity for at least 4 to 5 days of each and every week. Tobacco and alcohol use definitely increase one's risk of getting colorectal cancer. Smoking has been linked with a 30 to 40% increased risk of developing colorectal cancer. And obviously abstaining from smoking will reduce one's risk. Excessive alcohol is associated with increased risk of colorectal cancer. Even moderate alcohol, defined as 4 to 5 drinks each week, can put one at increased risk of developing colorectal cancer. There are certain high-risk categories of patients for colorectal cancer. Obviously, those people that have colon cancer in the past are at a higher risk, as well as those with prior history of benign but precancerous polyps. These people may get screened earlier or more frequently than the average person. There are certain familial disorders. We all appreciate that the family history of cancer puts one at risk. If, however, you unfortunately have a first-degree relative with colorectal cancer, that does put you at 2 to 3 times the average risk. For instance, the average risk is approximately 6% of the population, unfortunately, will be diagnosed with colorectal cancer. So if you unfortunately have a first-degree relative, your risk is 12 to 18%. These are the targeted patients we especially want to get to for colorectal cancer screening. There are other certain familial disorders that put people at even more risk for developing colorectal cancers, and even at an earlier age. The 2 common genetically inherited disorders in families include a disease they say is called HNPCC, standing for hereditary non-polyposis colorectal cancer syndrome. That's a mouthful, but that's a significant disease and warrants and merits early surveillance. So if you have 2 or 3 family members with colorectal cancer, you should see a physician earlier, because these cancers affect people as early in their 30s. The other most common form of genetically inherited disorders is FAP, familial adenomatous polyposis syndrome, which essentially the patients have their colons blanketed with polyps throughout their entire colon. They are at such high risk for developing colorectal cancer, they actually recommend prophylactic colectomy before age 21. So obviously you want to detect these people early on and screen these people even as early as their teenage years. However, the most important thing for everyone to remember is that most colorectal cancers are sporadic colon cancers. Those people that are asymptomatic, those people that have no family history of colorectal cancer. Most of the significant symptoms that would alert a patient to discuss this with their physician and possibly seeking referral to a gastroenterologist would be rectal bleeding. Although the majority of causes of rectal bleeding are benign etiologies such as hemorrhoids or vascular malformations or diverticulosis, polyps and cancers can cause bleeding. That's why once someone has experienced or had some rectal bleeding, they should probably have a colonoscopy to evaluate this further. Other high-risk symptoms would include a change in bowel habits. If you note a change in your bowel habits, whether you're always constipated and suddenly become experiencing diarrhea, or you always have loose bowels, but these loose bowels get worse, don't presume it's irritable bowel syndrome. Go discuss this with your physician. There's a perceived change in your bowel function that should prompt you to see your physician. If you are diagnosed with anemia, discuss this with your physician. Unfortunately, colorectal cancer often presents with asymptomatic anemia, and hence you should be referred to the physician. If you've developed unexplained pain, perhaps everyone has indigestion once in a while, everyone has some cramping once in a while, but if you have a change or you have a persistent pain, you should discuss this with your physician, because it might be indicative of something more ominous than just an irritable bowel. There are various screening tests recommended by experts. The simplest test would be that stool test analysis for microscopic blood. This is a very simple, easy, and usually very cheap test to be performed either in the physician's office or at home in the privacy of your own home, and you would then submit these stool samples to the physician and they could check it for blood. If there's any evidence of microscopic blood, regardless of whether you're seeing the blood or not, if that test is positive for microscopic blood, that should prompt further evaluation and could be indicative of a benign polyp that could have the potential to change into a cancer, an advanced polyp with a microscopic focus of cancer, even frank cancer. It does prompt further workup. In addition to the stool test, there are other more advanced tests that could be performed. Most common test performed in the United States is the gold standard test, colonoscopy. This has been proven to be the most sensitive and most accurate test to detect cancer either in its advanced or, more importantly, in its earliest stages, as well as detect polyps, the precursor lesions for colorectal cancer at its earliest stage, and allow the ability to remove these polyps before they degenerate into a malignancy. Other less invasive tests would be a shorter scope called a sigmoidoscopy. This is performed and has been performed for many years. However, most practicing gastroenterologists now favor the full evaluation of the colon, the colonoscopy. If someone prefers not to have any invasive testing, or for medical conditions cannot have any invasive testing or the anesthesia that comes with it, you could choose to have less invasive tests. The old-fashioned tried and true barium enema is a good test, not as accurate as the other tests. The new and fast approaching virtual colonoscopy is biting on our heels. Quite accurate, unfortunately not as accurate as colonoscopy. And even if it does become as accurate as colonoscopy, they cannot remove these benign polyps that colonoscopy can remove. Approximately 50% of people in the targeted screening population may have polyps. Therefore, colonoscopy is now still remain the gold standard test for colorectal cancer screening. Now that we've discussed colonoscopy in detail, I'd like to make the people aware that Southampton Hospital has a wonderful endoscopy unit. I am privileged to be the director of that endoscopy unit, and I'd like to introduce you to our charge nurse in the endoscopy unit, Sue Bonn, so she could discuss this further from her perspective in regard to the endoscopy unit and the wonderful job that we and she and our peers are doing at the hospital.
Welcome to Southampton Hospital's GI Endoscopy Unit, where I'll be going over some information with you in order to prepare you for your colonoscopy experience here. The best way for you to prepare for your colonoscopy is to follow the advice your physician has given to you. We don't expect you to seek advice from your family, your friends, or the internet. The instructions that the doctor went over with you in the office is what you're expected to follow. If you have any questions or concerns about the preparation, please contact that physician. Initially, the patient meets with the admitting registration, and then they're brought down to the endoscopy suite, which it comprises 4 rooms, one which is the admitting room. You'll be greeted by the staff, and we'll go over a series of questions for you to follow. We go over your medical history and how you prepared for your procedure. Once you're admitted into the procedure room, we hook you up to a lot of monitoring equipment. Our major concern is for your safety, so we monitor all your vital signs and place oxygen tubing in your nose. And we prepare you to meet the anesthesiologist who's on duty for the day, who will remain with you in the procedure until you do wake up. He does not leave the room until you are fully awake following the end of the procedure. The anesthesia that is provided for the patients is an IV sedation. We do use propofol here, which is a non-narcotic. It's very effective, and it's titrated to the exact amount for each individual patient, and patients are very happy with it. You do drift off to sleep for the duration of the procedure, and when you wake up, you're feeling like you had a great night's sleep and a well-deserved rest, as we always say here. The procedure is performed while the patient is lying on the stretcher. The anesthesiologist will provide the IV sedation. There is a minimal amount of discomfort that the patient may have following the procedure because the physician does instill a certain amount of air into the colon so that he can look through all the nooks and crannies. The discomfort that may be felt is the equivalent to some crampiness, and some patients don't have any at all. The patient can expect to remain in the hospital 30 minutes following the procedure. This is the time we make sure their vital signs return to their pre-procedure levels, and that gives time for the physician to come in to review the case with the patient, go over the procedure and any other recommendations and discharge instructions they may have. The patient cannot drive for 24 hours following the colonoscopy. We do appreciate when they have a ride available for them, and we try our best to make sure that there is a responsible adult to take them home. We do go over discharge instructions with the patient prior to leaving, and we make sure that they understand everything. There is additional information as the physician requires. If there's any additional prescriptions or diet changes that may need to be made, we go over all that with them. I've been in the GI field since 1986, which was also the start of my nursing career. And I will say, with all the advances that we've made in this field, that it's very, very important that everybody come and get screened. Colon cancer is preventable and treatable. Please come and get your colonoscopy so you can take good care of yourself.
Okay, Sue, thank you so much for walking our patients through what they could expect during the procedure and putting their mind at ease. Colonoscopy has been thought and proven to have contributed to the reduction and incidence of colorectal cancer. There's been some data collected from 2004 to 2007 that has revealed a 13% reduction in the incidence of colorectal cancer. That amounts to approximately 66,000 patients. Also, the mortality has fortunately decreased, approximately 12%. In that period of time, there were 33,000 less colon cancer deaths, and this has been thought to be attributed to colorectal cancer screening, including colonoscopy. If you could imagine this picture in your mind, a stadium full of people, it's Yankee Stadium, the playoffs are going on, and the stadium is full capacity, about 50,000 people. Over the next 5 years, colorectal cancer screening, including colonoscopy, can prevent death and save 50,000 lives. Just imagine a stadium full of people, and those are the number of lives you're saving just by utilizing colorectal cancer screening. I think that's a phenomenal picture to have in one's mind, and truly effective and backed by data. We could prevent colorectal cancer and increase the rate of colorectal screening, colon cancer screening, through public awareness. There have to be some outreach programs and celebrity involvement. Although the facts are there, and the facts have conclusively proven that colon cancer can be a beatable type of disease, it takes some sort of celebrity involvement to bring people for colonoscopy. The greatest evidence of this is Katie Couric. When she unfortunately experienced the loss of her husband, she got very much involved into colon cancer screening. She went on television and had a colonoscopy live on TV. And believe it or not, studies have shown that the rate of colonoscopies immediately after her colonoscopy on television had risen. So much so, when they plotted this on a graph, the graph didn't go up. The graph actually broke to a higher level of number of colonoscopies, and that's a great effect. And in the published data, they refer to that as the Katie Couric effect and documented in the literature. I hope we have some celebrities. Perhaps, Bob, you would want to have your colonoscopy on CTV. I don't know if that will help, but maybe it will. Okay? But we'll go to the next step. Public education is imperative. We have to make sure that it goes on a grassroots level. The physicians are discussing this with their with their patients. The patients are discussing it with their relatives. The greatest help would be having some people discuss this with their relatives after seeing this show and say, hey, Ma, hey, Grandma, hey, brother, have you had your colonoscopy? Because the key point is that the majority of colon cancers develop in people that are asymptomatic, the patients that have no symptoms, the healthy people. And the fact is that colonoscopy has conclusively been proven to prevent colon cancer. You're talking about the second or third most lethal cancer in the world, in the United States actually, and that you could prevent almost 70 to 90% of these cancers through a simple test via colonoscopy. Colonoscopy is an easy, simple, quick test. I would say the majority of our patients come into our wonderful endoscopy unit for under 2 hours, door to door. That's what I tell them. The procedure itself takes about 15 minutes. With the use of anesthesia, they are 100% comfortable, and they are in and out of the door in 2 hours. I really believe this is an important test for most people, especially the screening population over age 50, especially those with a family history should definitely have a colonoscopy. The point has to get out there that it's a treatable disease, and it's a curable disease, and it's preventable. There are very few cancers in which you could discuss prevention. I also believe that the mentality of the American psyche has to be changed. People often think of their doctors when they're sick. People often think of their doctors when they're feeling ill. They say, let me go see a doctor. I think the time for patients to see their doctor is when they're feeling well, before they're getting sick. They should come see their doctor and say, hey, doc, what can I do to reduce this kind of disease? What can I do to reduce colon cancer? What can I do to reduce heart disease? What kind of diet things can I do? What kind of tests are available? We have to change the psyche of America's perspective on healthcare. We should make this a preventive and protective kind of relationship with our physicians to promote good health, and see the physicians when you're healthy to discuss what you can do to stay longer on this earth and stay healthier on this earth, instead of seeing them once you get sick.
Well, that will be today's show, and I'd like to thank Dr. Georgopoulos and also Sue Bonn for their very informative show and the information. Certainly, I'd like to add my own personal plea for people to get their colonoscopies and to follow the advice of their doctors with regard to screening. Some of the figures are frankly startling. I'm also very happy that Dr. Georgopoulos did not talk the staff at CTV in me following the Coric effect and doing a live colonoscopy. I am very good about getting my colonoscopies, but I don't think I'm quite ready for prime time. I would like to thank all of you for watching today. In particular, I'd like to thank our friends at CTV for producing and airing the show in Southampton, our friends at LTV for airing the show in the communities in East Hampton. As always, if any of you have suggestions or thoughts about a future program, if you need help navigating our healthcare system on the East End, please feel free to give my office a call at 631-726-8555. Thank you, everyone, and good health.